Good evening, friends, and good evening, Dr. Sudhir and the team from ICU office. I hope you all are fine. So we welcome you all in the next session of STEP and program. It's a structured training and education program for nurses. So today's topic for discussion is nursing care of perioperative patient in the ICU. And the speaker is none other than Dr. Sudhir Khunteta, who has many crowns on his head. Dr. Khunteta is a managing director of Sub Hospital, and he is also director and the chief intensivist and chief physician of the Department of Critical Care in his hospital, and is looking it very well in this part of the country. Dr. Khunteta is in critical care medicine for the last, say, more than 20 years, and he has been very instrumental in organizing more than 15 conferences in this area of the country, in this part of the country. So, Dr. Khunteta, will you please start your presentation?
Good evening all. Thank you, Dr. Manish Manjal, for very elaborative introduction. I welcome you all for today's session, and topic is nursing care of perioperative patients in ICU. Today's objective is to define the phases of perioperative care, and we have to describe the scope of perioperative nurse practice. We have to identify the team of members and the responsibilities of each member, and responsibility particularly of perioperative nurse. History, when we find out the history of postoperative care, it starts from 1956, when the Association of Operating Room Nurses, they formed and they made a group to gain the knowledge of surgical principle and exploring the method of improving nursing care, particularly for the surgical patients. Because in the worldwide, 230 million surgical procedures are performed annually. And among these, 4% of non-cardiac patients die. And many much more percent develops complications. Even when we go to younger age group or some healthy groups, major surgery leads to many post-operative complications. Hence, there is importance of perioperative care. I would like to share one interesting resident. The ICU resident receives least frequency of calls between night of 1 a.m. to in the morning 6:59 a.m. But the mortality is highest at around 7 a.m. That means that's not only the availability of the nursing staff in the ICU is important. It's important there to be alert. They should be alert enough, and they should be able to recognize when this patient is becoming sicker. So they should send a call and should not delay in sending a call. While we discuss the perioperative care, it divides into 3 parts. That's preoperative, intraoperative, and postoperative. The first component is the preoperative phase that begins when the decision of surgical intervention is made. Once the patient comes to the doctor and decided that surgery has to be done, that's the beginning of preoperative phase. And when this patient reaches to the operation theater, that is the end of preoperative phase. In between these, whatever exercise, whatever measurements has to be taken, that comes under category of perioperative phase management. Second phase comes, that's the intraoperative phase, that's basic surgery part. And third phase comes, that is post-operative care. That's very important, and that begins as the patient admits into the post-operative care unit, ICU or recovery area after the surgery. And it ends when the patient gets either discharged or shifted to the general ward. Then why perioperative care and who want it? In a study of 88,500 surgical patients, it has found that the comorbidity, if patient is having comorbidity, there is a high hospital mortality. On which group? It is in older age. If we do urgency of operation, that depends. If the patient is having thoracic disease, cardiovascular disease, post-traumatic patients, gastrointestinal surgeries, kidney patients, respiratory cirrhosis and alcoholism, and non-metastatic cancer. When we go for surgery for these patients, there are high mortality rates. Then who can provide the care? Of course, a team which is formed by intensivist, ICU nurse, respiratory therapist, physiotherapist, primary physician, and some specialist if required. What is the purpose? The basic purpose is not to treat. Its basic purpose is to provide clinical information that this patient is either deteriorating or improving. So, important aspect is monitoring. The monitoring will not prevent the adverse event, but it reduces the risk of accident by early prompting the staff, by facilitating detection of consequences of human error, what has been done. So that is the purpose of perioperative care. What components are there in preoperative phase? Preoperative phase is the first is assessment. Second is history, then completion of diagnostic, that's preoperative investigations. Then the preparing the patient for anesthesia, preparing the patient for surgery. Surgeon or surgery specific preoperative orders, and there is need of post-op, special post-op care that's customized usually. So what is the goal of the preoperative assessment? The basic goal is to know the physical status of the patient. What is the functional reserve of the patient, because surgery is stress, and during stress, what reserve is needed. What is the comorbid condition of the patient and their severity? What is the optimization of these comorbid severities and surgery specific risks? Preoperative assessment, that's why we need preoperative assessment. This is to know in depth knowledge of the patient and optimization of the pre-morbid conditions to reduce the morbidity and mortality post-operatively. So what assessments are necessary? That's physiologic assessment, that includes age, history. History is a very important part because it tells about the old diseases of the patient, general conditions of the patient. Then allergy history, immunological status, immunosuppressive status of the patient. Then physical examination, that includes vital signs and usually systemic examination. Level of functioning of the patient to assist in the patient's care and rehabilitation, knowing the patient reserve and all. Presence of dentures and dental prosthesis, we should make note of it so that intubating team have the knowledge that this patient is having dentures and dental prosthesis. Obesity, if it is, it should be recorded. Record the height, weight, just to know the doses and other things. Fluid and electrolyte imbalances, if there, that should be known to us and that should be corrected. If there is any infection, because surgery is a stress and any stress will flare up the pre-existing infections. So we should know that if there is any ongoing infections, and HIV, HBsAg status, we should know prior to surgery. Previous drug history and alcohol use, that should be known. Respiratory status of the patient.
Dr. Sudhir, I will interrupt you here. There is one attendee who wants to who has raised his or her hand. Neha Burman. Neha Burman, do you have any question? Neha Burman.
Probably गलती से लग गया होगा.
Chalo, Dr. Sudhir, please continue.
So we were on the part of the taking drug history and alcohol use. We should know the respiratory status, pre-existing disease, and there is a respiratory reserve of the patient. We should know about the respiratory reserve of the patient. Cardiovascular status, because cardiovascular diseases increase the risk of complications. Hepatic and renal function, we should know about it because they are very important. If patient is having gross renal function disturbances, then surgery is relatively contraindicated unless it is very much required or to correct the renal functions. Hepatic disease we should know for the because all anesthetic agents get metabolized into the liver. Presence of trauma, endocrine dysfunctions like diabetes, corticosteroids, hypothyroidism, status of the patient, and importantly, allergies, sensitivity and past drug reactions, and immunosuppressive status of the patient. We should know all these in detail. Medical histories, the patient is taking medicines, particularly adrenal steroids, diuretics, phenothiazines, antidepressants, tranquilizers, insulin, and antibiotics. Because all these drugs have interaction, they are important for some drug reactions with the anesthetic agents. Psychological assessment is an important feature which we should take care in the preoperative period, because every patient have fear of unknown. I don't know what will happen. Their fear of pain, fear of death, fear of anesthesia. They are concerned about the how much duration will be there for their absence of work, and when they will have the permanent disability or not. So we have to deal with all these situations pre-hand. Consent is an important part that comes in the pre-operative phase, because nowadays the medico-legal aspect should be, it's a very important aspect. So there is informed consent. You should inform all the consequences of the surgery, duration, its risk, benefits, everything has to be informed to the patient and take a valid consent.
Dr. Sudhir, will you please show your previous 2 slides again? Somebody has asked.
Psychological assessment.
Okay. The next one.
Pre-operative learning.
Yeah, this is regarding the pre-operative learning.
Pre-operative learning, I skipped it because I was going to detail in future next slides, but okay. Still, the patient, we should know pre-op learning. This patient, we should teach the patient pre-operatively that you should have such exercise. Say for example, the tribal exercise. We should teach the patient pre-hand. So in the post-operative period, he takes up what he has learned in that period. Lifestyle modification, stop the smoking, stop alcohol, and like this. So not only consent to be taken, that should be a valid consent. Every surgery, every invasive procedure, every procedure which involves sedations, anesthesia, or radiations has informed consent has to be taken. Consent to be taken if patient is adult by himself, or if he's not adult, then family member or legal guardian is to be taken. Now, this consent paper should be well preserved and keep under control. Optimization. Optimization is an important feature, because once you have assessed the patient, now this deficits has to be optimized before surgery. Means the patient who is having psychological disturbance or psychologically having anxiety and fear, you should be empathetic to him. You should talk to him, communicate him thoroughly, ask his fears, remove all the concepts which he is thinking that surgery is going to happen with him and causing this damage, So that should be explained in advance, relieving his tension, allay her anxiety, and make him relax. Nutrition is an important factor, because if there is any important nutrition deficiency before surgery, that should interfere with the tissue repair at a later date. If patient is dehydrated, fluid corrections is an important thing that should be done, and monitor closely for alcoholic patients, because when we stop alcohol, they usually develops delirium tremens, which is a psychological disturbance, and that happens usually within 72 hours. So goal is to maintain the body in the hemostasis. That the slide I'm showing, that was this is here. Ask patient to optimize respiratory and cardiovascular status, optimize him, stop smoking, breathing exercise, teach them diaphragmatic exercise, coughing, spirometry, and other things we have to teach them pre-hand. 6-minute walk test is an important test which we can do, especially to know the respiratory reserve. It's a simple test. 720 steps has to be taken in 6 minutes, and if there is a fall of 3% of saturation, then the patient is having less respiratory reserve. Hepatic renal function should know. Diabetic patients, blood glucose level should be under control. If patient is taking steroid, that fact should be known to the anesthetist, because the steroid cannot be stopped altogether. Anemia is an important part, because oxygenation to the body is done through the blood. And if there is less blood, the tissue hypoxia will be there. So if there is anemia, that should be corrected. And if you think there will be loss of 500 or more of perioperative blood, then anemia correction should be your priority. Mobility and active body movements, you have to teach different positions in the bed to the patient is going to be in post-operative period. Teach any special position required after surgery. And for the DVT prophylaxis, you should teach them leg exercises in advance. Remove jewelry and wedding rings and all articles. That has to be handed over to the family members. Take signature of them. If someone, for some reasons, refuse to remove the jewelry and other, that should be securely fastened with the tape. In brief, what steps to be taken in preoperative phase? Identify the correct patient, verify surgical site and mark its site, preoperative assessment, assess for any post-operative complication. If there, then risks involved should be explained. Consent, perioperative expectation and complications which can happen, that should be noted down. Intravenous line to be taken, medications, pre-medications, whatever is ordered, that should be done, and make patient comfort and psychologically relaxed. Then comes the intraoperative phase. Basically, intraoperative phase is when the patient goes into operation theater to the recovery room. That phase is basically managed by surgeon and his team. So we are not describing in detail here. Then comes important post-operative phase. Post-operative phase begins with the admission of patient to the recovery area and ends with the when the patient is either being discharged to the ward or going to the home. What common problem we are encounter during perioperative period? That's post-operative nausea, vomiting is the most common. Then anaphylaxis, post-operative pain, electrolyte imbalances, chills, rigors, hypertension or hypotension, bleeding from operative sites, cognitive impairments, and sometimes malignant hyperthermia because of anesthetic agents. So in the perioperative care period, we first shift patient to immediate care, and that is PACU, that is post anesthesia care unit. Ensure patient is stable before transfer out from OT. So that is the area where we keep the patient for a while and observe, and if patient is fit to shift, then shift from OT to ICU or ward. Shift to ICU if patient is requiring ongoing post-operative care, if he needs critical care, if patient is unstable, or there is some special need, is a customized need for the patient. When patient received in the ICU, initial hours are critical, and you have to ensure hemodynamic stability. You have to ensure ventilation, assessment of incisional pain, surgical site integrity, treat nausea and vomiting, neurological status and cognitive status of the patient. It is a well-known fact that more than 50% of older patients develop post-operative confusion. The important aspect is of keep family in loop. Keep family informed about the procedures, about the frequent assessments, necessary equipments which are available there, appropriate monitoring, and all these information has to be transferred to the family from time to time. Post-operative pain management, that's a very important part, because effective analgesia is an important part, because patient and his relatives are more concerned after surgery that the patient is having pain. Not only this, there are adverse effects of poor post-op analgesia. Patient develops tachycardia, hypertension, sometimes myocardial ischemia can develop, disturbance in alveolar ventilation because of pain. Patient takes shallow breathings, decreased vital capacities, and ultimately poor wound healing, transition to chronic pain, and insomnia. Insomnia again causes disturbance in cognitive and other complications. And analgesic agents can be given oral, intravenous, intramuscular, transdermal patches, intranasal, epidural, regional anesthesia, and rectal. And that depending upon the orders you received from either anesthetist or the ICU in charge. Nowadays, multimodal analgesia is quite in vogue. This is a combination of systemic pharmacological agent that's given IV with a local, intra-articular or topical anesthetic agent, plus sometimes required regional anesthetic agents. So combination of 3 or 2, that is multimodal analgesia. It is so a complete analgesic phase is achieved. Usual agents are NSAID and coxibs and acetaminophenes. Extended release epidural morphines, fentanyl patches, gabapentin pregabalins, local anesthetics, patient controlled regional anesthesia, that is in vogue nowadays. The patient controls the doses of analgesic agent. What monitoring has to be done in the post-operative period? Important is hemodynamic monitoring. Hemodynamic monitoring is both invasive and non-invasive. Continuous ECG monitoring is required, pulse oximetry, continuous monitoring, NIBP monitoring, that's initial every 15 minutes for 1 hour, afterwards 30 minutes, every 30 minutes for 2 hours, and then hourly monitoring should be done if patient is stabilized. Temperature, every 4-hour temperature should be measured. ABG, ultrasound technology is used, I'll describe later on. Invasive BP monitoring, radial artery blood pressure or pulmonary artery catheterization, whatever facilities available in your hospital. ETCO2 monitoring, T is used to know the ejection fraction, the stroke volume of the heart, and JVP. Now ABG is indispensable. ABG is easy nowadays, available in each ICU with their dedicated machine usually, and there are multiple new parameters nowadays available. You can see there is anion gap, anion hematocrit, hemoglobins, lactate, creatinine are all available in each ABG reports. So we can detect early deviations and detect early metabolic acidosis and other complications. The common respiratory complications which we encounter in the early perioperative period, it's pneumonia and atelectasis. Atelectasis because of incomplete expansion or collapse of alveoli. There is a retained mucus plug, and that is called as atelectasis. And similarly, pneumonia develops due to aspiration, decreased cough reflex, and increased secretions. How to prevent these respiratory complications? That's head end of bed in semi-fowler, keep in this semi-fowler position. Oxygen therapy, analgesia, incentive spirometry, deep breathing exercise, coughing while splitting, that we have taught in the pre-anesthetic phase. Postoperative pulmonary edema can be detected nowadays early with the lung ultrasounds. Ultrasound in the perioperative management. Ultrasound is very important nowadays in ICU, especially in perioperative management, because it is non-invasive tool. It's available bedside. It's relatively cheap. We can hemodynamically monitoring can be done, echo and other things. Detection of internal bleeding, collections can be detected. Guided surgery procedures can be done. Putting vascular access, nerve blockade, etc. can be easily done with the ultrasound. ECMO is also important in post-operative care. ECMO is required. Bedside ECMO is available nowadays, and ECMO is required to manage the respiratory and circulatory failure. Portable ECMO is available now for the transport of the patient. You can use portable ECMO machines. Ventilators. Ventilators are an important part of post-operative care. Lung protective ventilations, use of low tidal volumes. We used to keep on ventilator the patient who are undergone abdominal, major abdominal surgeries, transplant surgeries, cardiac pulmonary surgeries, post-traumatic and neuro surgeries. Ventilator is support is usually given to them. Electrolyte imbalance is common and usually hyponatremia encounters in the post-operative phases, and 30% of children develops post-operative hyponatremia. Ongoing post-operative care, frequent assessment has to be done. There should be a post-operative checklist. So there should be a flow sheet, and that compare with the initial assessment. Diagnosis of actual problem, what's going on. Continuous plan of care should be defined, and individualized care about his, including his risk factors, surgical procedure, and patient need. We should individualize the ongoing care. Hypertension is common in post-operative period, and hypertension usually develops because of sympathetic nervous stimulation, because of pain. That's why pain relief is analgesia is an important part. Hypoxia and bladder distension, so they should be avoided, so hypertension can be controlled easily. Dysrhythmia because of respiratory dysfunctions, drugs, hypothermia can cause dysrhythmias. Hemorrhage, you have to monitor for the hemorrhage, internal bleeding, drainage, operative sites, and urine output is an important feature which can suggest us that some blood loss is going on. Shock, thrombophlebitis, and pulmonary embolism. Urine elimination. Urine output is an important part in ICU, so you have to monitor intake output charting. You should assist patient in normal positioning for voiding. Bladder distension has to be kept an eye over the bladder distension, because distension causes hypertension again. So if your patient is not voided within 8 hours of surgery, then you should inform the consultant. Provide privacy. That's important, because patient cannot void his urine unless privacy is there. Catheterized if there is indication for the catheterization. Similarly, bowel elimination is important. You have to auscultate your bowel sounds every 4 hours. If there is no bowel sounds, then there can be paralytic ileus. You assist in the help in the passing motion, and maintain again privacy, and apply, you give the suppositories, enemas, other medication for, or stool softener for the constipation, to avoid the constipation. Wound care. Sometimes wound dehiscence occurs and sometimes bleeding from the wound site occurs. So that should be always looked frequently. Drainage has to be seen, because if some internal bleeding is there, drainage is put just to see some internal bleeding is there or not, or if some collection that comes out. Monitor wound dressings, and teach the family and patient to take care of wound when shifted to the ward and room. Some fact we should know that related to nutrition. Malnutrition increase risk of poor wound healing. So pre-anesthetic assessment, if patient is malnutrition, having malnutrition, that should be corrected. Obesity itself is risk factor for wound infection, wound dehiscence, and since fatty tissue has poor blood supply, so there is increased risk of infection and delayed wound healing. As we have already told that the infant have more hyponatremia. Similarly, they have lesser total blood volume. So there is more risk of dehydration or fluid overload, and they have more oxygen requirement. So they should be taken care of accordingly. Increased surface area of the children make them prone to hypothermia and hyperthermia. There is a loss of their longer effect of muscle relaxant and narcotics because they have immature liver. Old age is, again, there is a decreased metabolic state. Old age is a decreased metabolic state and decreased renal function. So anesthetic drugs and other complications do happen because of this decreased metabolism. Cognitive disturbances occurs in more than 50% of old age. Delayed wound healing and chronic illness or comorbidities make them special. We have to discuss some legal aspect of the post-operative and perioperative care. The professional nurse is obliged to protect the patient right of safety. So that is, patient safety should be a major concern in the perioperative period because patient is not in his control. Role as patient's advocate, you have to see that there should not be incompetent, unethical, or illegal action or practices going on with the patient. That should not be there because you are only attendant of the patient in the perioperative period. You should be qualified enough to administer your care. You are obliged to maintain the highest level of competency in nursing practice through continuous education activities and continuous activities as we are doing today in our STEP program. Statutory law. Law says the registration with either Indian Nursing Council or State Nursing Council is a must to practice in any hospital. Legal doctrines, that's important in the perioperative period because captain of ship doctrine that says, as if in Navy, the captain is in charge of everything. Similarly, in the intra-op period, surgeon has full responsibility of the care and efficiency of the procedure room and welfare of everyone who is there. Second important doctrine is respondent superior doctrine that says that subordinate acts according to his superior's direction. That hospital is liable for negligence action of nurse. That doesn't mean that you should do negligence because the next doctrine says that res extra lectutor. That says that you as post-operative nursing care or ICU nursing care, you have practice much more frequent than the person who or the nursing staff who is working in their OPD or other general ward. So according to your eligibility or efficiency, standard of care should have to be delivered by you. If there is any standard of care which were expected from you has been breached, you are liable to yourself. Then how to avoid legal injuries? Consistent adherence to uniform policy, procedure, and protocols. Every hospital has made protocols and policies, and you have to follow it consistently. Because if any injury happens while following these codes or protocols, it will be easier to show that the nurse compiled the policy and procedure of the institute. So it's your responsibility regarding, that's important again, I'm re-emphasizing it, that informed consent. You have to obtain the consent, define the consent, explain the consent, document it, and placed in health record safely. Few final words. Skill requirement of perioperative nurse, that because perioperative nurse plays a role of assisting doctors, serving liaison between patient and doctor. He is communicating between family and patient. You should have skills, and you should develop a skill of technical skills, detail oriented. You should be a critical thinker. You should be able to change yourself with a fast paced environment, flexible, multitasker, effective communicator. You have to team player, and you should have emotions. So that is the logic of perioperative care, because first we should develop system that there should be no mistakes, but no mistake cannot be achieved. By mistakes do happen if we work. So early identification of mistake and treating that mistake or complication is the logic of perioperative care. I hope now we will work to achieve the triple aim, that's delivering high quality service, better patient outcome, better and more efficient use of resources available, and better patient experience in your hospitals. Thank you. Thank you for your nursing to the word to health. Thank you all. Thanks for patients hearing. Dr. Munjal, I invite if any questions are there. I'm not hearing anything.
Sir, I'll just check with Dr. Manish Munjal. I would request the participants, if they have any question, to kindly put the questions in the chat box, please.
I'm not getting my chat box here. Dr. Munjal, I think they are gone. There are no questions. I'm not getting any questions. Urine related care and post-operative slide once again. Okay. Here it is. You can unmute and ask.
Okay, so just let me check, sir. I'll unmute some of the participants. If they have any questions, they can ask you directly.
Anirudh, you want to this slide? If you are hearing me.
No, sir. You can stop. You can stop slide sharing, sir.
Okay. Then there is a request to share this slide of urine. Started something thing. Pre-op corticosteroid drugs.